All right, let's start chapter 13 today. We're going to go over the peripheral nervous system. So remember, central nervous system, brain and spinal cord, and peripheral nervous system is everything else. So that's going to be all the nerves and receptors associated with getting information to the central nervous system. Remember, we have our sensory division. Is that afferent or efferent? Afferent, which means it's going to or away from the brain? To the brain. And then what inputs come out of the brain? Starts with an E. Motor or efferent, exactly. So all efferents they're all motor responses. And those might be going to glands to change hormones. They might be going to actual muscles to make us move. But something is going to happen with those motor efferent responses. Of the motor division, we have two, what have I done here? We have two divisions of that. We have somatic, which basically we have control over, and then autonomic, which we don't have control over directly, although we can, to some degree, control it with our cerebrum if we think hard about it. If you're really careful, you can try to relax and lower your blood pressure and your heart rate. All right, so here we have the major nerves of the peripheral nervous system. Remember, everything's either going to come from a spinal nerve or it's going to come from a cranial nerve. So those are the ways out of the central nervous system. And we have that in the spinal cord, we have that widening up there, the cervical plexus and the lumbar plexus. And those represent all the additional nerve bodies needed to get information to and from the limbs. Wow, I'm really having... To get a sensory perception to go in, we need to have some energy being transduced into an action potential to go to our brain. So we have lots of different kinds of receptors. We have light receptors. We have mechanoreceptors that sense pressure. We have chemical receptors that are going to sense the changing chemical milieu around a given cell. And then each receptor has a receptive field that it can detect changes in. So this is, and each receptor can be different. Some have pretty big receptive fields, some have really small receptive fields. Do you think that the nerve endings, the mechanoreceptors that sense pressure in your fingertips, have a small receptive field or a large receptive field? So if we want high discrimination, we need to have tiny receptive fields, right? So we would have really big receptive fields maybe on our shoulders or back, where you still want to feel stuff, but you don't need to know if it moved 1 millimeter over to the left. Of the sensory receptors, we have two types. We have these generator potential receptors and then receptor potentials. And basically, it just means these are the two different types of potentials generated by receptors. So generator potentials are just everything's all together. The stimulus is on one cell. The stimulus produces a graded potential that may or may not cause an action potential. With a separate sensory receptor, we have a different cell that's going to release neurotransmitter. So it's more like a synapse. So if that cell, if the graded potential generated at the plasma membrane on this receptor cell is sufficient to cause release of neurotransmitter, then this second neuron will be stimulated. So which one do you think is faster, the receptor potential or the generator potential?
Generator.
Yeah, because it's direct. It's the same thing as when you add lots of synapses in a nerve pathway, it's going to slow things down.
When are you expecting this exam to be? Last week of the semester?
Yeah. Now, as we talked about in lab, remember when we put the quarter on Shayna's arm and then Ryan's arm? Pretty quickly, those girls couldn't really feel that quarter, at least not well. But if you add enough quarters on top of it, they can feel it again. So most receptors are phasic receptors, and they actually, they will adapt really quickly. So they let you know right off something's happened, and then they quit letting you know. They figure, okay, I've alerted you, I don't need to continuously alert you. They will often tell you again at the end. So while you may quit feeling the quarter on there, when I take the quarter off, most subjects can feel where it was. Again, they're notified of a change. So notification of change without ongoing notification is common, and that's what happens with phasic receptors. Some receptors, on the other hand, need to continually notify you. And what big category of receptors do you think needs continual notification that something is ongoing? If it's going to be damaging.
Like a burn. So,
yep, exactly. So the pain receptors that are going to feel a burn or feel that, nope, ongoing, like, you know, I'm hurting my hand by doing this, and that change I made, nope, didn't fix the pain. My hand still hurts, so I need to make some change so that I'm not damaging myself. Those are tonic receptors. Some tonic receptors can have a little bit of adaptation, but it's usually slow. Many have almost no adaptation at all. So it is a classic thing. It comes up in animal medicine a little more than people medicine because you guys ask your patients how much it hurts. But for me, if I want to know if something hurts an animal, I do the thing that hurts. And if I just can't tell if he's antsy or whatever, like, is the horse pulling his leg away from me because he doesn't like me holding his leg or because that hurt? If I keep doing it, pain is repeatable. It is consistent over and over. So if you find a spot that hurts, it's like that Bart Simpson episode. Ow, quit it. Ow, quit it. Ow, quit it. Like over and over. They will continue to, nope, that hurt. Nope, that hurt. Because every time that nociceptor is going to fire. And they will continue to do that. So those two, the two big categories are pain receptors, which is nociception. Often those are going to be stretch receptors, like in the gut, or temperature receptors. And then also proprioception, because we need ongoing inputs as to where our body is in space. If unusual proprioceptive inputs are being communicated, they tend to continue to be communicated. And again, I think it's a, you know, don't want to get hurt or need to know where your body is in space. So where do we interpret sensory information? What part of the cerebrum? Where is it located? Or you could read this line.
The parietal lobe?
This is the parietal lobe. What part of the parietal lobe?
Somatosensory cortex.
Yeah. So remember we have the somatosensory cortex and the motor cortex in the parietal lobe. And that's where all of this sensory information is going to be interpreted after it's been relayed there via what? That starts with a TH. That's in the middle of our brain, the thalamus. So we get inputs that go up the spinal cord, relayed in the thalamus, and they're going to go to the somatosensory cortex, where they're interpreted, and then some sort of motor output is decided upon. Ooh, this one's not going to work, is it?
That's unfortunate. That'd be funny if that happened to me, Kayla.
Or not. Yeah, that guy was actually very well could have been really seriously hurt.
Do it again.
I will do it again.
What was the point of that?
All right. So. Yeah,
what was that showing?
Branding a horse. But what are you talking about the other?
Oh,
like,
yeah,
what
here
was
we go.
the point of us watching?
So what happens with this horse? Oh God, what have I done? Oh, just stop that.
It's just an ad. Okay, you can skip it. Have you used
200
YouTube?
horses were suppressed in a heavy storm. Like, what is happening with this? Why is YouTube doing this? Well, anyway, you guys saw what happened. We're going on.
No, can we give you just watch it? I don't understand why we watched it.
All right. I'm going to explain. I'm just having technical
It's right there,
difficulties.
it's right
Is it somewhere?
Man gets kicked by a horse.
Oh God, there we go. Okay. So what happened here? Stop. Just
The horse
stop.
was like knocked off. That hurts.
so
Okay,
we have two creatures. Oh my God, this has got to stop. Oh, actually, this is a really funny video. Actually, I've seen
Let's
it.
just watch it. Yeah, wait.
You guys wanted to get out of the
driving class
Guys,
gone
I
wrong.
wanna
Yeah, one of these horses escapes and he starts running around and around and around for like
No.
7 minutes, and everybody's trying to catch
their
him.
carriage.
Yeah. So let's go back to the actual PowerPoint so we can get out of here before Lauren revolts and/or vomits. All right, we have two creatures associated in that transaction, right? So let's talk about the horse first. The horse is in stalks. He's probably already a little scared. He sees somebody coming towards him. He feels pressure applied to his right flank. Stimulus from that receptor fire, those receptors start firing. They're going to go to his spinal cord. They're going to cross over to the left side, travel up to his brain via the thalamus, get to the somatosensory cortex, where information is going to be processed. And he's going to have to detect that happened, right? Then he has to estimate the magnitude, like, is this a little tickle or is this something big? And he very quickly decides this is a very significant thing that just is happening. I'm not like, this is really big. So then he has to kind of try to discriminate exactly where is this happening. He probably didn't do that so much in this case because it was a really big stimulus. So it gets harder to make small distinctions when you have a huge input. Then we need some feature abstraction. Like, he needs to kind of decide, this horse, like, what's, are there any specific features that are happening here? So again, probably didn't happen with really big stuff, but imagine feeling like a fabric that has, like Ashley's sweater, a fabric that has some texture to it. You know how sometimes you can feel like the pill of the fiber and how thick it is? Those are the feature abstractions. They don't happen very much with really big stimuli. So if you get punched in the face, you probably didn't like carefully feel each knuckle that you can feel if it's a really gentle touch. So those things go down with the magnitude when you have a big magnitude. We have to discriminate quality. Is this, what's happening here? Exactly what is this sensation? And recognize some sort of pattern. And the pattern that this horse is going to recognize is that I was in stalks and somebody walked towards me with this long thing, and then something really painful happened. And so ultimately that's going to go to the motor cortex and then go create a motor output. In this case, it was kicking that poor veterinarian off the screen. So in the case of the vet, he also had a really big stimulus. He probably didn't have much feature abstraction, probably couldn't discriminate much. But his pattern recognition will still be there as well. He also learned from that experience. And next time that he goes to brand a horse, he's probably going to stand somewhere where he's pretty darn sure he can't get kicked again, right? So all these things are happening. And I guess it's a complicated system, but an impressive one.
So is it like the features of the pain go down magnitude?
Features.
Or
No, so what I'm trying to say is there's features of perception. We have all these different things. In that particular example, a few of them probably weren't playing a big role. Mm-hmm. Discrimination of between 2 points, probably not huge. That would be much bigger with, gentle touches or a feather or something. Okay. All right, so let's talk about pain perception. This is going to come up for you guys a lot in your jobs. So much of your job is going to be discussing your patient's pain and trying to help deal with their pain. Pain is called nociception. Pain perception is called nociception. And many pain-inducing stimuli are also part of the inflammation cascade. So they are related to our immune system, because remember, inflammation is the innate immune system, at least for pain. Extremes of temperature and pressure and lots of chemicals are going to stimulate nociceptors. So a big chemical that we're going to see over and over is prostaglandin. But what else happens in tissue when you have tissue damage? We can get histamines released. We get substance P. You guys remember that one? So substance P can be released in tissues when they're damaged. Acids, bradykinins are inflammatory mediators.
Why did you say histamine twice?
Because it's really important. It just gets released once, probably. But what about potassium? Why do we see potassium at the site of pain when pain is being percepted? Why would potassium be something that would stimulate a pain perceptor? Where is potassium in our bodies?
In the blood.
Is it?
And the cells. Outside the cells.
It's very specifically inside the cells, right?
Yeah.
Because what's outside the cells?
Sodium.
Sodium. That's what's in our blood. That's why it tastes salty. Inside our cells, we have potassium. So why would pain perceptors respond to potassium?
Is it something, I don't know.
Would it have to do with like pressure and like potassium getting like moved in the cells or getting like pushed out of the cells?
Released. So if we damage cells and lyse them open, we release potassium into the extracellular space. So potassium can indicate cell damage, which is why pain perceptors respond to it.
Oh, that's why nursing instructor was saying that if you find someone that's like crushed by something, you don't want to like take it off them so quickly because then everything is rushed out of the cell.
And that can often be like, if they've been there for a while, that'll be all the muscle products, all the lactic acid that's built up because their muscles and tissues will have tried to go on without oxygen as long as possible. So yeah, you could totally flood the body. Like if they have a tourniquet on and you take the tourniquet off, if you've had loss of blood flow to a limb or crushed or whatever. So we have two kinds of pain receptor, pain fibers, these that will transmit pain signals. We have small myelinated fibers. Pretty much all pain fibers they're small, but some are myelinated and some are not. The ones that are myelinated are called A delta fibers, and they tend to respond to temperature and pressure. We have these small non-myelinated fibers called C fibers, and they tend to respond to chemicals. Why do you guys think there's a difference? Which one's faster? A delta fibers or C fibers? A delta, why?
Because they're myelinated.
They're myelinated, so they're faster. So is it more important to give temperature and pressure changes, extreme changes in temperature or pressure, more sort of importance, or response to things like potassium leaking out of cells?
Can you say that again?
So I guess I'm asking, why do we have A delta fibers that respond to temperature and pressure, and then we have these slower pain fibers that are responding to chemicals? And it's because we're needing to give precedence, right? If you are burning yourself or
Getting crushed.
exactly, then you need to move really quickly, whereas these chemical signals are going to take a lot longer. When you damage cells, it's going to take a while for potassium to diffuse out of them. It's going to take a while for prostaglandins to be produced and histamine to be released. So those fibers can be smaller. Generally speaking, with receptors, most drugs are going to act on receptors as either agonists or antagonists. So here we have the natural substance acting on a receptor, and something happens, some cellular activity. When we have an agonist drug, it will bind to that receptor just the way the substance did and stimulate it to do much more of that thing. So those drugs usually bind more tightly, they cause more effect. And then we have antagonist drugs. And antagonist drugs also take up the receptor site, but they take it up in a way that doesn't stimulate the cell, and it keeps the natural substance from binding there. And remember, this can go both ways. So we have some receptors that stimulate cells and some receptors that inhibit cells. So we can either promote excitation or inhibition, or we can inhibit excitation or inhibition. So it depends what your receptor does and what your drug does. You could have a positive and a positive, a positive and a negative and a negative, or a negative and a positive, right? Does that make sense? All right, so I don't know if this is going to work, but
Is it not a bonus video?
no, it's a really great, so
Hello,
this is
in
one
this
of the
video,
better
we're gonna
videos
talk
I've
about
ever
pain.
seen.
We're going to focus on the ascending pathway of pain, and we're also going to talk about the descending pathway. As well, we're going to focus on an area called the substantia gelatinosa. Imagine you had a right hand injury. What happens, and how do we feel pain? The pain signal coming from the site of injury will travel up to the brain, and this is where the perception of pain essentially is felt. The signal going up to the brain is referred to as the ascending pathway. Injuries to our body is felt in certain areas of our
area called the substantia gelatinosa. Imagine you had a right hand injury. What happens, and how do we feel pain? The pain signal coming from the site of injury will travel up to the brain,
called the
and this is where the
somatosensory
perception of
cortex.
pain
Let's
is
recap
felt.
the brain
The signal going
briefly.
up to the brain is referred
Here's
to
the
as
cerebral.
ascending pathway. Injuries to our body is felt in certain areas of our brain called the somatosensory cortex.
Cerebrum,
Let's recap the
brainstem,
brain,
and cerebellum.
briefly.
The somatosensory
Here's the
cortex
cerebrum,
sits posterior
brainstem,
to the
cerebellum.
central sulcus.
Somatosensory cortex.
Let's get a
sits
cross-section of the brain like so and zoom into the
central
somatosensory cortex.
Let's get a cross-section of
The
brain
somatosensory
like
cortex is
so
an
and zoom
area
into
where
the
sensation is perceived.
cortex.
This includes pain.
Somatosensory
The
cortex is an area
somatosensory
where sensation is perceived.
cortex has
This
areas
includes
which
pain.
correlate to different parts of our body. So for
Cortex
example,
is
let's look
areas
at the left side of the
which correlate to
somatosensory
different parts of
cortex.
our body.
The outer
So, for
region
example,
here
let's look at
represents
the left
the
side of the
leg,
somatosensory
hand, and
cortex.
face.
The outer region
Again,
here
this is your
represents,
right
leg,
side.
hand, and face. Again, this is your right side,
And this is your left
the
side of the brain.
brain.
The brain continues on and joins with the brainstem, which is made up of three main components: the midbrain, pons, and medulla. These are cross-sections of the brainstem. The brainstem then continues on and becomes the spinal cord. Here we are only looking at one section of the spinal cord. Let us say this section of the spinal cord is the cervical spine area. The spinal cord has nerves coming out from the anterior root and nerves coming in from the posterior root of the spinal cord. Here I am only drawing the nerves on the right side of the spinal cord. Different tracts exist within the spinal cord. One tract important in the pain pathway or the ascending pathway is the spinothalamic tract, made up of the lateral and anterior spinothalamic tracts. Let's go back to the right hand injury now. The right hand has an obvious injury on its palm. Within the area there are immune cells residing. When these immune cells are damaged, or should I say when any cells are damaged, including our skin cells, they start releasing cytokines, chemicals. An important one in the ascending pathway are prostaglandins, represented here as PG. Prostaglandins are produced by nearly all cells, typically as a response to inflammation. Sensory nerve fibers exist all over our body. These sensory nerve fibers will respond to prostaglandins and will carry the signal or impulse to the back of the spinal cord or the dorsal horn of the spinal cord. This neuron is a first-order neuron. Within the dorsal horn of the spinal cord, the first-order neuron will synapse and relay this signal, this impulse, to the second neuron. This second neuron, called the second-order neuron, will cross over to the opposite side and will enter the spinothalamic tract. From here, the second-order neuron will continue up, ascending through the remaining spinal cord, through the brainstem, and terminate in the thalamus of the brain. The thalamus is the relay station. In the thalamus, the second-order neuron will synapse with a third-order neuron. The third-order neuron will carry this impulse and relay to the region of the brain which correlates with the injured right hand. Thus, the third-order neuron helps discern the area of injury, and also the cortex here is where the perception of the pain is perceived. Important to remember that this is the left side of the brain, whereas the stimuli, the initial signal, was on the right hand. Thus, sensation always is on the opposite side of the brain to where the stimuli or stimulus occurred. Another important thing to remember is a chemical released by the first-order neuron to transmit or relay the signal impulse to the second-order neuron. This chemical is substance P. Thus, substance P and this whole area at the dorsal horn of the spinal cord is an important area for the ascending pathway. Now, whenever there is an ascending pathway, there is a descending pathway. While the ascending pathway is responsible for transmitting the pain signal up to the brain, the descending pathway is responsible for controlling and inhibiting the ascending pathway essentially. Important areas of the descending pathway include the periaqueductal gray matter of the midbrain and the nucleus rhabdomagneus of the medulla. When not inhibited, the neurons arising from the periaqueductal gray matter will go down to the nucleus rhabdomagneus and synapse with a second neuron. This second neuron here is a serotonergic noradrenergic neuron. And this serotonergic noradrenergic neuron will travel down towards the dorsal horn of the spinal cord as well. The serotonergic noradrenergic neuron's role, in summary, is to inhibit or control the communication between the first-order neuron and the second-order neuron of the ascending pathway, and thus help control pain signals going up. There is another neuron here I'm drawing in blue, which also plays an important role in this area, and we'll talk about it later. So this dorsal horn of the spinal cord is a pretty important area. We can call it like a gate, so gate control of pain. If we zoom into this area of the dorsal horn of the spinal cord, it can actually be referred to as the substantia gelatinosa. So let's just recap this whole area. Here we have the first-order neuron coming in and synapsing with the second-order neuron here. The first-order neuron will bring in an action potential, which will eventually stimulate vesicles to release its content into the synaptic cleft. The content here in this case is substance P. Substance P will stimulate the second-order neuron. The second-order neuron is stimulated and will propagate an impulse up to the thalamus via the spinothalamic tract. Coming down from the medulla here in red is a neuron from the descending pathway, the serotonin noradrenaline neuron, which will release its content, serotonin and noradrenaline. These chemicals, or this neuron, will do two things. Firstly, it will bind onto receptors of the presynaptic neuron and inhibit the release of substance P. Second, it will stimulate a small neuron in an area called an interneuron. This interneuron in the substantia gelatinosa is actually an opioid neuron, which when stimulated will release an endogenous opioid called enkephalin. Enkephalin, like all opioids, will do two things in the substantia gelatinosa. One, it will inhibit the presynaptic neuron from releasing substance P. And two, it will inhibit the postsynaptic neuron from depolarizing, and thus stop the continuation of the impulse up to the thalamus. All in all, opioids such as enkephalins will inhibit the ascending pathway of pain. So that was an overview of the ascending pathway and the descending pathway of pain.
So, this is a really nice overview to try to help us figure out what are the pain medications that we have and what are they going to do and where do they act. So let's start talking about the substantia gelatinosa, and that's the area that we just saw in that video. Let's first look at the first order neuron. What could we do to this first order neuron to stop pain. Is that an excitatory neuron or is it inhibitory? When it does its thing, does more pain happen or less pain? If it releases neurotransmitter, does more pain happen or less? More. And you can tell because that neurotransmitter is substance P, which is basically always a pro-pain neurotransmitter. So how can we inhibit the first order neuron from releasing neurotransmitter onto the second order neuron in the spinal cord? We can do that a couple ways. One, we can take advantage of this descending pathway. This is a noradrenergic and serotonin releasing nerve here. So we can add serotonin. So we can actually take tricyclic antidepressants and they will have an effect on pain, especially chronic pain. Substance P is what's being stimulated or is what is being released. And we can block the release of substance P with opiates. So we can actually take opiates and that will act right there. It will block the release of substance P right here.
Is that why there's such like an opioid addiction? Because people are just, well, obviously abusing them and then they need opioids to stop.
We'll get into it a little bit more, so give me a sec, okay?
Okay.
The other place that opiates act is on the second order neuron that's going to ascend up to the brain. And it's going to inhibit substance P from stimulating this neuron. The next way that we can get opiates is we can actually stimulate our interneuron to produce more of them. Opioid receptors, so if these are pain fibers, these yellow ones, remember that we have C fibers and A delta fibers. The C fibers have more opiate receptors than the A delta fibers, which is why opiates are more effective against pain transmitted by those fibers, or slow pain, generally those types of chemical pain. We may have.
What did you say about C fibers?
So C fibers are the small, non-myelinated fibers. They tend to respond more to changes in chemicals, substance P, prostaglandin, histamine, and those are more effectively inhibited by opiates than are the fast pain fibers that transmit information about things like extreme changes in temperature or pressure. So yes, anything, I think we kind of went over all the things here, but basically opiates work here and serotonin will also work here. So tricyclic antidepressants like serotonin reuptake inhibitors will have some effect on pain. Now, this is certainly simplified because that descending neuron can be stimulated in other ways as well. There's all sorts of glutamate and GABA receptors up there, so various other chemicals can stimulate this descending neuron from up higher. So there's more potential for pain control using those receptors as well. Now, we said that this descending neuron is a noradrenergic and serotonin receptor. Has anybody heard the term noradrenaline? Anybody know, you've heard adrenaline? What's another word for adrenaline? So it would be 1 to 1,000 or 1 to 5,000 given emergencies. Epinephrine. Okay, so epinephrine is the American way, or adrenaline is I don't know, I think they use that maybe in Britain or Scotland, but epinephrine and adrenaline are the same. So noradrenaline receptors are the same thing as norepinephrine receptors. Now, we talked about using serotonin to change our pain pathways, but what about noradrenaline? Can we use that? And it's a complicated answer because yes, we can, but it also has profound other effects. Norepinephrine acts in so many places as part of the sympathetic nervous system that when you inhibit norepinephrine, you have just these really incredible effects everywhere. So we do have drugs that do that. The most common one is called an alpha-2 agonist. And it's going to have these really profound sedation effects, but also incredible pain control. So if I had an animal that was throwing himself down and writhing around in pain like a colicky horse that's completely out of his mind with pain, I can give him an alpha-2, and 30 seconds later, he's going to be sedated and not acting painful. And then 18 minutes after that, when that alpha-2 wears off, he's painful again. So it's a really, really powerful sedation, but also pain control, because not all sedations are going to provide pain control. When you guys give your patients Valium, there's almost no pain control involved with that. So the other receptors we have that I mentioned that are with those descending pain pathways are going to be NMDA receptors. And NMDA antagonists are things like ketamine and tramadol. So they're going to, ketamine, for instance, is going to interact with GABA receptors. And remember, GABA is generally excitatory or inhibitory. It's one of the main ones that's usually inhibitory. Okay. So if we cause more GABA, we inhibit more. So ketamine is a really potent drug as well. That also, again, incredible pain control with ketamine.
Allison?
Yeah.
Can I ask you a question?
Yeah.
Were the roads bad on your way here?
No.
Okay.
Why?
How far are we
I guess
going
they're
on
bad
this?
at home.
Oh, really?
We have, I'm guessing, another 10 or 15 minutes. Okay.
Are we going through the whole presentation?
Yes.
Like chapter 13?
Wait,
But not all of chapter 13. We're going to do pain,
okay.
and then we have cranial nerves. We have pain, we have the anatomy of the nerve, and we have cranial nerves.
And the next test is going to be on 13.
14, 15, and 16.
Michaela,
So,
who told you they were
Um,
at home?
My step.
so this guy is a nice little chart that talks about non-narcotic. When I say narcotic, I mean opiate, non-narcotic pain meds, and where they're acting. So again, we have, oh boy, it did not go through that. Huh.
Where do you live?
Middlesex. So, sorry, let me just go back to this slide that talks about what is happening in the tissues. Where the heck happened to that slide?
When
All
I
right.
worked at the vet, like at 2 different vets that I worked at, tramadol was like a huge thing that some people used to abuse.
Yeah, there was a vet
Like
that was
described to.
Their pet, and they would take it.
So let's look here. Somehow I've managed to take a slide out by accident. I'll try to put it back in before I put it on the website. So down here at the tissue level, remember in our video he mentioned prostaglandin?
Yeah.
There's also other things produced at the tissue level. What can we think of that's produced at the tissue level? Sorry, this is an important part that I totally missed there. Histamine, right? Red and itchy. Substance P will be produced at the tissue level. Prostaglandins. So, let's see what else. Potassium. There's not a lot we can do about potassium receptors, but certainly, remember, substance P receptors can be neutralized with opiates. So that means that opiates not only act centrally, but they also act peripherally, which is why they are such incredible painkillers on their own, because they're acting at multiple sites. What drugs, remember when you guys did your presentations? I think solidly half of you, when we did those little PowerPoints on drugs that will cross cell membranes. Do you guys remember what you chose? What did you choose, Ashley?
Isoflurane. That's an anesthetic.
Anesthetic?
Yep.
I feel like a few people chose things like aspirin and ibuprofen.
I did ask.
Aspirin?
I did ibuprofen.
Ibuprofen?
What the heck did I have?
You have some
Lorazepam?
Maybe. Maybe I want to
Xanax or
do.
something?
So,
I think it was Xanax.
aspirin, acetaminophen, ibuprofen, those all act at the tissue level. Okay, so those are going to stop the production of prostaglandin. So those are pain medications, and they act peripherally, but they do not act centrally, which is why you can take ibuprofen and not get loopy, not like seem stoned or whatever it is. The way that you see like people when they take opiates, they'll get, obviously have this really they can have a really significant change in behavior, because opiates are going to act centrally and peripherally, whereas our Tylenol, actually Tylenol does act centrally, but not as much on pain receptors centrally. It seems to act on fever, the fever center in the brain, I believe, is how it reduces fever so potently. But as far as pain control, the huge effect of these is going to be peripheral. Antihistamines would help. And this is kind of an interesting chart for you guys to look back at. I mean, there's all sorts of ways to help pain. We can use things like cognitive behavioral therapy to try to change what's happening in the brain, and hypnosis. So there's other options. And then what's one more option? When you go to the dentist, has anybody ever had Novocaine?
Yeah.
Yeah? So all the canes, Novocaine, lidocaine, mepivacaine, all of those are local anesthetics. They're sodium channel blockers. So they block action potentials in nerves. So those will work anywhere. You can put in an epidural and you can block conduction through the spinal cord, right? And you can totally stop pain there. You can put a local anesthetic in around a wound and the person won't be able to feel the wound anymore until that wears off.
Is an epidural, like when you're giving labor, is that considered a local anesthetic?
Yep. So that would be, sometimes they'll put sedatives in there as well, but it's going to be some sort of lidocaine, mepivacaine, one of those.
But, okay, so is it true that epidurals don't really work for everyone?
Epidurals work for everyone if they're put in the right place, but it's really hard to put an epidural in exactly the right place. So it's certainly, there's some amount of operator error.
Okay.
So yeah, if your technician or the anesthesiologist could be perfect every time, then they would get, yeah, lidocaine works on everybody.
Gotcha.
Oh, here we go. Apparently I go through the tissues down here, sorry. So this is at the tissue level. We have the inflamed cells, and I'm talking about substance P and prostaglandins, Tylenol. Boy, there was something I wanted to bring up. Sorry, give me 1 second. What were we talking about just a moment ago before that question?
Epidurals.
Epidurals, lidocaine.
Yeah.
Novocaine. You were talking about how it blocks action potentials.
I'm like the old lady that you guys have to help remember.
Like before that, even?
Yeah, it was before that.
Tissue production? Like what tissue produce?
Well, I'm hoping I can remember and come back to it because it was something.
Tissue level and then central level.
Yeah, I'm sorry. I'll have to come back to it with any luck. So let's go through addiction. Like, why does this happen? It's much more complicated than we could say in this class, or even that we really know about. But definitely things like opiates, if you're really firing pain receptors a lot, then your opiates are going to glom on and be used up at those receptors, and there's less of them to happen centrally. So when you're taking large amounts of drugs over time, there ends up being more of a central effect. So you'll see bigger behavioral changes and things. Remember, we have long-term potentiation. The nerves are more likely to fire. If you make that path through the field, those nerves get really good at firing. So even small stimuli can make those pain fields oh, now I got it. Now I know what I was going to say. Can make them fire. And this is actually a really fascinating topic, is like how pain pathways get started. And if you can, with your patients, stop those pain pathways from being established, you will have such a better time of getting control of their pain. So who's heard of phantom limb pain? Yeah? So it's like totally a documented thing. Somebody can have a limb removed and the limb still hurts and it's not there. You can't do anything about it if it's not there, right? So here's a really interesting little research study. When people are having amputations, if they not only have anesthesia, and I'll take one step back here. What happens with anesthesia? A painful thing still happens, right? So histamine, prostaglandin is all still produced in the tissue, but we are shutting off the brain from paying attention to that. So it can't do anything about it. If, on the other hand, when you're doing an amputation, you put Novocaine, lidocaine in as an epidural in the spinal cord, you do a spinal blockade so that those signals never make it to the brain, that pathway never gets established. And the numbers of people who have phantom limb pain will drastically reduce.
Yeah, but doesn't that make the procedure more painful?
No, it makes it less painful.
The
So
actual procedure.
Not only do you have anesthesia, so not only do you have anesthesia, so you don't, like, your brain can't tell it's happening, but it can't perceive, those neurons are not transmitting anything. And so this is actually a great question into the other part of this, is just with basic procedures, if you use local anesthetic as well, so instead of just sedating somebody, if I also put in, an animal in my case, if I also put in local anesthetic, the pain will never be as bad once that anesthetic wears off. So if you have a dental procedure and you're knocked out for it and they pull a tooth and you wake up and you have some level of pain, right? If you have the exact same condition, same procedure, but instead that nerve was blocked so that it could not transmit all of its pissed off messages while your tooth was being pulled, you have less pain even once that block has worn off, and it never gets as high as it was. So if you don't ever get those pathways established, you'll never get as much pain. So getting on top of pain soon after surgery will actually, it's really hard if you get behind the pain curve to get on top of it for your patients. And that's the biochemical reason why, is because these pathways have this potentiation, short-term and long-term. With addiction, we have not only potentiation, but we also, when we have a lot of something, we tend to down-regulate the receptors for it. So that's why people need more and more, they crave more and more drug, because even though those pathways are sensitized and those nerves are firing really easily, there's not as many receptors to make them fire. So you get a net downgrading of sensitivity. Does that make sense?
Yeah.
So anatomy of a nerve, it's very similar to a muscle. We have an individual axon that's wrapped in this case, a myelin sheath, and that individual axon has an endoneurium around it. A bunch of those axons surrounded with their endoneurium is encased in a perineurium, and then we have multiple perineurium plus vessels that are going to be encased in that epineurium, which is always the outermost layer. It's not quite like a muscle, because with a muscle we have the muscle fascicles as well, but it's the same kind of idea. 3 layers of membranes. So what's the bulk of the nerve? Is it axon? What color are nerves when you see them in a wound or in they're white? And so that's all this connective tissue, and it's the myelin. Nerve functions. Most nerves have sensory and motor functions. So most of them are going to be called mixed nerves, and both afferent and efferent impulses will travel through them. This is pretty cool. So we talked about quadriplegics and paraplegics and how once that damage, once you get rid of the inflammation and you've done what you can, like, that's it. The damage is there, it's done. You can't fix that. However, most of you have also cut your fingers, and you cut nerves then, and yet you still have sensation in your fingers or around those wounds, right? So peripheral nerves can regenerate. Central nerves cannot. So anything in your brain or your spinal cord cannot regenerate. And all the nerves in the peripheral system can. And this mostly is because of the Schwann cells that form myelin in the peripheral nervous system. They actually promote regeneration, versus the oligodendrocytes in the central nervous system that are going to inhibit regrowth of neurons. You'll grow new neurons almost like 1.5 millimeters a day. And if scar tissue happens to grow in the way before the nerve can re-meet where it's the other nerves that it was communicating with, then you may never get reconnection of that particular axon, but other nerves will try to grow around it and reconnect as much as possible. Cranial nerves. Look, there we go. Virginia's glamorous hat and vest.
What was it supposed to be?
We're not saying that again.
Something vagina.
Yeah, there was a vagina involved. It
And a
was terrible.
lesbian, right?
I think it was the lesbian who told, oh man, that's like never leaving my
What
head.
was the hat?
Hymen.
Oh, yeah.
So now we're going to touch and feel Virginia's glamorous hat and vest. Much better. Yeah.
Oh, to touch and feel vagina.
Oh my god.
Oh my gosh.
There we
Yeah,
go,
that
okay?
was interesting.
Yeah.
For sure.
So we've gone through most of these in lab, and you guys know about them already. We have olfactory. Remember, size matters, so the olfactory bulbs in animals that use their noses for a living are going to be much larger than those that don't. We have a pretty poor sense of smell, all things said. So, you know, a bloodhound, a sheep, most of those animals are going to have better noses than we do.
Oh, so a lamb was considered to have big olfactory.
Those were large olfactory bulbs. Yep. We have to have an awake patient to test olfactory. Optic, kind of same thing. It's vision. So it's that's actually a purely sensory nerve. I think the olfactory is actually purely sensory as well. Oculomotor, trochlear, and abducens are all going to have the same general goal of moving the eye around in its orbit. And just keep in mind that abducens and trochlear are both lateral movement of the eye. So sometimes you'll see a patient that has eyes that are aimed towards his nose or aimed medially, and that's very likely a deficiency if it's both eyes in one of those cranial nerves. Or it can be one cranial nerve on one side. The trigeminal is really important. It's really big. We've got 3 branches. It does do some taste. Exquisitely sensitive when you have people that have trigeminal neuralgias. That can be very, very painful. Yeah, it really does. I think there's sensation to almost all the face from the trigeminal nerve. The facial nerve is equally important, but it's almost all motor. And these are the 2 biggest cranial nerves, in humans at least.
Isn't there one like right here?
Yeah, so it comes right out, yep, and it's going to wrap around the face. We've got 5 different branches of the facial nerve that are going to innervate different parts of the face.
This test for
Oh yeah, hypocalcemia.
hypercalcemia.
What?
So, for patients that you suspect have like hypercalcemia, I can't remember which type.
Hypo, I think.
Is it hypo?
It's hypo.
You like tap their facial nerve,
Really?
and if their face twitches, they have it.
That's so cool. I have no idea what that is. So you have to bring me more information on that. I want to know more about
Or if you put a blood pressure cuff on their arm and you inflate it, their hand contracts like uncontrollably.
Like, they can't control it.
that. Really? Well, that's pretty cool. I did not know this. I want more information on this. Facial nerve is big. It has motor divisions, like I said, to all parts of our face. And I want to give you an example. When I was a nice, bright, shiny, enthusiastic young veterinarian, I anesthetized a horse for a castration. And of course, this particular horse was worth a lot of money. Always happens to the ones that are worth a lot of money. And he was so bad too. He was just he was so naughty. He would give me such a hard time. He hated needles. He was always trying to kick me. And so I laid him down, and I didn't want to take his halter off because I was worried like he doesn't do well with sedation. I thought he's going to jump up in the middle of surgery and I'm going to have his horse running around. It's going to be terrible. So I left his halter off. And the halter has a metal buckle here, and it didn't have a buckle. It was just a flat ring, but it had a flat ring on the side of his face. And of course, he didn't wake up in the middle of surgery. Instead, which was even more ulcer-inducing, he slept for like an hour and 15 minutes when it should have been 25. And so here I am, you know, my gastric ulcer happily bleeding into my stomach as I'm hoping that this horse is going to wake up. And so he finally does get up, and he was down on his right side, and the halter was on the right side of his face. And when he woke up, his muzzle was not centered anymore. And he actually had a little bit of droopiness to his eyelid and everything too. So which way was his muzzle deviated? He was laying down on the right. I injured his facial nerve on the right-hand side, which means those motor impulses were no longer being sent. So what happened to his muzzle? How did I know what I did?
Did it cross over to the other side?
It went
So,
this way.
Yeah.
Exactly. It went away. So that motor nerve,
Wait, what were you doing to him?
castrating him.
What does that mean?
Removing his testicles.
Oh. Wait, I knew that. But why is that relevant to the kid?
Because I had to anesthetize him to do it, so I laid him down on the ground. So I anesthetized him and laid him down, and I didn't want to take his halter off because he was so naughty. And he'd had such a hard time with sedation. Like previously, I'd given him so much sedation, and he'd just be like,
Oh, so the pressure of
so
that
it's the
ring
pressure when I,
entered the
yep.
okay,
So when I laid him
understand.
down, I left the halter on, and that metal ring pressed against his face. And when he woke up, his muzzle was deviated to the left. So he was laying on his right side. His muzzle was deviated to the left because these muscles were working fine. So they pulled his muzzle to the left, but the muscles that were supposed to pull his muzzle to the right were not working anymore, and so they couldn't pull the muzzle to the right. So it did go away after time. I treated him aggressively, but it took like 2 months.
Were his
2
owners,
months?
like,
Oh,
wicked
God.
mad?
Yes.
Because he's probably a show horse.
Oh yeah, he was
Yeah,
worth
more
like
blood or whatever.
$150,000. Yeah. It was all fine. They remained good clients, but they definitely were a little like, we called you to castrate a horse, and now he's got this problem with his mouth. So anyway,
Unfortunate.
that was unfortunate. There's a lot of things you learn. All right, vestibulocochlear, so equilibrium in hearing. You'll test these by looking for signs of staggering. Everybody stand up for me. I know, we're almost done, I promise. Stand on one leg. Are you guys good? Can you all stand on one leg? Yeah? Close your eyes without holding on to anything else. Makes it harder, right?
Yeah.
So you can open your eyes if you want. So vestibular cochlear is equilibrium in hearing, but it's going to definitely rely on inputs from all these other things, not just the semicircular canals. So you get inputs to the vestibular system, not just from the vestibulocochlear nerve. Otherwise, if we were standing here with our eyes closed, our semicircular canals, unless I'm going to fall, shouldn't inhibit or shouldn't feel anything different. But as soon as I take away that visual input, it gets a lot harder. So vestibular system is much bigger than just this one nerve. Has to be tested on an awake patient. Glossopharyngeal. This is motor and sensory to the tongue. Remember 9 was testing with donuts, along with which other one could we test with a donut, even though that's not its primary function?
Bagel.
Vagus. Yep, so vagus is typically autonomic nervous system. SNS, PNS, we have some swallowing though, so we can make sure it's intact. And then we have 11. The accessory nerve comes from spinal nerve roots. And this is going to be shrugging your shoulders and pivoting the head left and right. So if your patient can do those two things, his accessory nerve is intact. So these are mostly motor to the neck. And then hypoglossal is mostly motor to the tongue. So sticking your tongue in and out will test the hypoglossal nerve. And here's just the testing cranial nerves page. And that is it. I'm so sorry that it took forever. Have a nice weekend. I'll put up questions for this, chapter 13, for you guys if you can have them in on Monday. That'd be great. Thank you all. See you soon.